So I'll be presenting a case of a 24 years old female who presented with us with complaints of gradual painless diminution of vision in her left eye since 3 months. Her visual acuity was 1 by 60 and there was no improvement in it. So on seeing her fundus, we saw a very large juxtapapillary yellowish white lesion, which was approximately 3 disc diameter by 3 disc diameter in size. And it had some calcification and subretinal fluid, which was encroaching the fovea. On seeing the autofluorescent image, we can see some hypoautofluorescent regions which show the calcified area in red, and some hypoautofluorescent area which signifies the decalcified area shown in blue. So on doing the OCT and OCTA, we can see a very large choroidal lesion with which is shown with the red arrow, and this is a hyporeflective lesion with hyperreflective dots, which has overlying RP atrophy, some CNV formation, intraretinal pockets, cystic pockets, and this CNVM net can again be observed on OCTA. So on doing FFA and ICG for this patient, we can see early patchy hyperfluorescent choroidal filling pattern with a late diffuse staining. And on ICGA, we can see a early hypocynescence followed by diffuse multifocal hypercynescence. And it becomes confluent in the later transits. On doing the B scan imaging, we see a slightly elevated choroidal mass, which is highly reflective even at low gains. And there's a very characteristic sign which shows shadowing and sound attenuation, which is known as the pseudo-optic nerve sign. And this one is very characteristic of this disease. So all her systemic investigations were within normal limits and there was no evidence of any systemic associations. So a diagnosis of left eye choroidal osteoma was made. And the patient was given left eye intravitreal injection of aflibercept. After 6 weeks on follow-up, we can see signs of resolution setting in. Her visual acuity, though, was still the same. But if we observe closely at the OCTA images, we can see there is some regression of the CNVM net. So we decided to go again with the second dose of the same injection. On 12 weeks, her maximum resolution was observed. Even her visual acuity improved to 6 by 60. The CNVM net regression was also there. The IRF pockets resolved, and even the lesion, which was the choroidal lesion, it also started regressing. But after that, due to some reason, she was lost to follow-up and she had a delayed follow-up on 22 weeks, where we can again see the recurrence of SRF and IRF was there. And again, she was injected with aflibercept. And after 26 weeks, we can again see that there was resolution. So patient is still now kept under very close observation, and now TTT is planned for her. So basically, choroidal osteoma is a rare benign ossifying tumor, which is usually juxtapapillary and macular areas. It is unilateral, has a predilection for young females, and very important, there should be no established systemic associations. Generally, we can see CNVMs, serous retinal detachments, sometimes hemorrhages, a choroidal mature cancellous bone are few of the signs of the disease process. Tumor decalcification and resolution can be seen, and it shows a yellow-gray atrophic area, overlying RP, choriocapillary atrophy. If this is present, the patient will have a very poor visual prognosis. And this might be spontaneous or it might even be triggered by laser photocoagulation or PDT. So generally we have no standard treatment for osteomas, but we need to treat the complications which are due to CNV or SRF. And we have the options of anti-VEGF injections and laser therapy in the form of transpupillary thermotherapy, photodynamic therapy, and even laser photocoagulation in some cases. Thank you for your kind.
Nice presentation. For the sake of the audience, before we go for FFA or ICG, BCG is a very handy and non-invasive tool with which we can screen these lesions of choroidal osteoma. Ultrasound, I'm telling. Ultrasound. You have already shown. I saw.
I did all the multimodal imaging in this case.
Yes. That is for the sake of presentation, but for clinical diagnosis, we should go with, because that is there just next to our cubicle. So we can do that. After that, we can confirm. Nice documentation. And maybe you can try some more injections before embarking on TTT, because sometimes
so she has been already injected with 5 injections, and
Okay.
I just showed you 4 injections. She has had 3 injections of aflibercept and
Okay.
2 injections of brolucizumab till now. So she has a seesaw pattern.
Okay.
Till the time the effect of that injection is there, her fluid goes down, the lesion starts getting decalcified, everything regresses. But as soon as that effect wanes off, again those changes come back. So now we were thinking that since CNVM net is also regressing, why not try the laser therapy? Might halt her things or not.
But
Okay.
what was the interval between the injections?
Approximately 6 weeks, ma'am. We follow up every 6 weeks, uh, apart from one
For
point
aflibercept.
for aflibercept, yes. But after brolocizumab, that period has increased to 10 weeks to 12 weeks.
But what was the reason for switching from?
Because, ma'am, again, it was recurring. So since we gave her 3 injections of that, 4 injections of that, and again we were seeing that there is a same pattern, we thought why not we try with the latest molecule and see what is the effect coming.
I don't think brolocizumab has been used in
No,
osteoma with.
not yet, not yet,
Yeah,
not yet.
you should put that up as a case report.
Yeah,
Actually.
we are planning to do that, ma'am. Yes, ma'am.
Yeah.
Nice
But
case.
5 injections is not much.
Not much, not much.
So yeah,
Yes,
don't
ma'am.
lose hope and please continue treating her.
Sure, ma'am.